Hello and welcome to the lecture on Intro to Mechanical Ventilation. This is the first one, so we're just going to be talking about some basic terms to start off with and some basic concepts. But these concepts, even though they're basic, it doesn't mean that they're not important. In fact, these concepts, having these down is really going to benefit you in the long run. So when we get started here, I want you to think about the application of these, and I'll try to give you some examples, and we'll go through some examples in the lab as well to try to nail these concepts down to a practical skill level. So when we're looking at this, knowing your definitions is going to be a key aspect. I will ask you to recall these definitions. They are important just to make sure you have good basic understanding of the concepts down the road. Between this lecture and the next one, there will be 5 learning objectives. And this one will stop at airway resistance. So if you're reading or following along in your Pilbeam Mechanical Ventilation book, we'll stop at the airway resistance part for this lecture part 1, and I'll do a lecture part 2 to follow. Big thing here is ventilation. We're going to look at ventilation versus external respiration and internal respiration, which if you remember back from pulmonary A&P, external respiration is between the alveoli and the bloodstream, and internal respiration is the metabolic exchange between the bloodstream and the tissues, the capillaries of the tissues, right? So there is a definition, and when we look at even things like metabolic rate, well, it increases your oxygen requirements. Well, as your oxygen requirements increase, so does your minute ventilation requirements, which means if you're putting someone on life support or you're thinking about putting someone on life support, if they have an issue with their minute ventilation requirements or their oxygen requirements, that could easily cause them to go into respiratory strain, into fatigue and failure ultimately. So we're going to need to know all of these different aspects to help us out. I do want you to sort of be able to think about intrapleural and alveolar pressures and the changes that occur not only with normal spontaneous breathing, but also with when we put someone on positive pressure ventilation, whether it's non-invasive positive pressure or invasive positive pressure. It's going to change the physics of how you breathe, and it's also going to change your normal values. When we switch someone from breathing on their own with spontaneous lung compliance is going to be way different than someone on a ventilator that's using positive pressure to push the lungs open, to push the chest wall open, to push the diaphragm and everything out of the way. Well, of course, compliance will automatically decrease if we put someone on positive pressure ventilation because we're not having that natural suction and pulling open of the chest wall. So it's important to know those differences and what happens with that as well. And when we get into advanced critical care medicine, we start talking about things like esophageal pressures and how esophageal pressures will usually equate to pleural pressures. And we're going to want to have a good understanding of that as we're going into this. So that's why the pressure changes during both positive pressure and spontaneous are going to be pretty valuable to you. So pay attention to those. Transpulmonary pressure, transrespiratory pressure, transairway pressure, transthoracic pressure. Those are going to be your 4 ventilating pressures involved not only with spontaneous breathing, but with positive pressure breathing. And any of those factors can really impact how the breath is delivered to a patient. And obviously compliance and resistance. Every time we go in to see a vented patient, 2 things that you should be trending or paying attention to, amongst many other things, will be compliance and resistance, because it tells you what's going on with their disease pattern. That's part of what's going on with their disease pattern, right? If I see someone's compliance or how stretchy their lungs are is going down and down and down, it could be something with their chest wall, it could be something with their abdomen, it could be something with the lung tissue itself getting stiffer, right, like a pneumonia developing, or pleural fusion developing, right? Or if I see someone's airway resistance keep going up, it could be a buildup of secretions or inflammation or bronchospasm, right? So these are all things that can help us trend and see if our patient's disease pattern is getting better or getting worse, if we need to do a new or another intervention to help their disease pattern or not. So that's why we need to follow these things. We need to look at alveolar pressure changes when we're looking at this during normal quiet breathing. And we'll also talk about how when we look at plateau pressures, a little preview here, that represents alveolar or respiratory zone pressure. And so it can give us the health and what's going on with the respiratory zone. The other advantage to knowing these pressure changes is it can help us see how much force or how much workload the lungs have to do to overcome breathing. When someone has air trapped in their lungs, they're not going to be able to have as much change in pleural pressure, as much change in alveolar pressure to pull in each breath. So it's going to make them work harder with their muscles to pull in each breath by breath, which then fatigues, right? All the muscles that you're using to breathe are skeletal muscles. That includes your diaphragm, right? Your external intercostals, not only for inhalation, but also your muscles that you need for exhalation. If you're air trapping, you're having trouble getting gas out of your lungs. So by definition, one of the things that we have to look about here is getting to see when we're going in to evaluate our patients what their work of breathing is. If that's something that they're working hard to breathe and they're on mechanical ventilation, that's an important thing to note. That's an important thing to communicate. That's an important thing to troubleshoot. So we need to look at those things as well. So looking at pressures while breathing is going to come in handy, especially like I said earlier, when talking about esophageal pressures and looking at transthoracic pressure or pressure changes that we need to keep the lungs open. Calculating compliance and resistance are standard. Those are on not only the board exams, but they're also something that we do at the bedside, something that we see that we need to be trending on these patients to tell us where their disease process is going and how they're trending. Changes in peak pressure during ventilation, that's going to be a very common thing that we're going to look at. Most patients are going to be on, adult patients are going to be on volume targeted ventilation or volume controlled ventilation, where we set a delivered tidal volume based on their predicted body weight. And then the variable that changes is going to be how much pressure it takes to deliver that breath. So as I see how much pressure changes, that can tell me either a lung compliance, air resistance, or both are changing, and that tells me, okay, is this patient getting sicker? And if so, what's causing it? Is it a compliance issue? Is it a resistance issue? And knowing these things are really going to help you as a vital part of that care team, especially one that's supposed to be an expert in mechanical ventilation. The other things that we'll look at is conditions that could lead to increased airway resistance. So I'll give you a little case study there. We're going to look at some things easily that you can think about and evaluate at a bedside without a chest x-ray. And of course, chest x-rays are always helpful, but what are some things you could do at the bedside to sort of evaluate what could be causing their increase in airway resistance, or a decrease in compliance, or the opposite, what's causing their compliance to get better, or what's causing their resistance to decrease, right? So those are all things that we'll talk about here. You do need to be able, of course, to calculate the airway resistance given a peak airway pressure, a plateau pressure, which we'll talk about as well. And remember, from pulmonary IMP, we did talk about calculating your compliance as well as calculating your airway resistance using flow. Do be aware, most mechanical ventilators use flow in liters per minute, and the calculation for this is in flows in liter per second. So you will have to convert it to liters per second to perform that calculation. So just a quick reminder there. So let's talk about normal spontaneous breathing, right? So ventilation, spontaneous ventilation, just quiet breathing, which hopefully almost all of you are doing right now, is the movement of air into and out of the lungs. So that's just ventilation. Ventilation is movement of gas. Once again, ventilation is movement of gas. Movement of gas into and out of our lung. When we start talking about respiration, this is the exchange of CO2 and O2. I can move a lot of gas into and out of my lungs, but if I'm not exchanging CO2 and O2, I'm ventilating, but I'm not respirating, right? I'm not exchanging CO2 and O2, and that's the primary difference. If I have someone that breathes a tidal volume of 100 mLs, just 100 or 200 mLs, super tiny tidal volume for an adult, right? And I have them breathe even super fast, really fast, like let's say a rate of 60 breaths per minute. Are they going to be able to exchange a lot of CO2 and O2 breathing rapid and shallow? Well, no. Are they ventilating? Are they moving gas into and out of their lungs? Yeah, they're moving gas. They're ventilating, right? They have minute ventilation going on. But do they have exchange of CO2 and O2? Do they have respiration? They do not, right? So that's where it comes into the big deal. That's why in critical care techniques you probably talked about the rapid shallow breathing index, right? Where we look at the rate and the tidal volume to see, okay, is this patient a weaning or extubation candidate based upon how rapid and shallow they're breathing? So when we're looking at respiration, it's the exchange of CO2 and O2 between the environment. So external respiration here is going to be the diffusion of oxygen and carbon dioxide between the alveoli and pulmonary capillaries. So you're using external gas to exchange CO2 and O2. When we look at internal respiration, another way to think of internal respiration is metabolic, right? When I like to think about this as metabolic rate, it's the exchange of oxygen in my capillaries and my tissues to the CO2 from the tissues into the capillaries, right? It's that metabolic exchange, it's the gas exchange at that tissue level. So that's what we're looking at here. Internal respiration, think about it as metabolic rate. Well, why do you care? Well, we talked about metabolic rate being a factor in someone's oxygen consumption and how much oxygen their body requires. So if their body requires a lot of oxygen, they're fighting off an infection, they're running a massive temperature, they're going to consume a lot of oxygen, their metabolic rate's going to increase, their oxygen requirements are going to increase, and therefore their minute ventilation, right, has to increase to support that. Right? And so these are all things that factor into each other. So we do need to know the difference between external respiration, which is actually the exchange of gas between the pulmonary capillaries and the alveoli, and then internal respiration, which is the exchange of your capillaries and then your tissues, whichever tissues we may be talking about. Accessory muscles of breathing. So traditionally, for normal, spontaneous, quiet breathing, you're using your diaphragm and possibly your external intercostals, depending on the source. So those would be your two passive or primary muscles that you use for spontaneous breathing. So both of those, right, when the diaphragm contracts, it moves down, it expands the chest wall, and it allows for the chest wall to open up, and then you're going to have changes in your alveolar pressure that's lower than atmospheric pressure, and gas will pull from a high atmospheric pressure to a low pressure that's in your alveoli, right, and air is going to be sucked in. But that's for traditional spontaneous breathing. So that would be your diaphragm, and then possibly your external intercostals. Well, if we are still having a hard time getting gas into our body, if we're not getting a deep enough breath, we can recruit accessory muscles to help us take that big breath. So some accessory muscles of inhalation, of forced inhalation, right? You're going to take a super giant deep breath in, would include your scalenes, would include your sternomatoclastoids, those ones at the front of your neck, your pectoralis, your traps, all those help expand the rib cage, right? They help pull the rib cage open. So think of the inspiration muscles, accessory muscles, as all muscles that pull the rib cage open. Well, conversely, let's say we have a lot of gas that's stuck in our lungs. Let's say we have a lot of air trapping during an asthmatic episode or during a COPD exacerbation, right? We have a lot of air trapping. We're having trouble getting gas out. We're trying to force that gas out and we can't. Well, we can also recruit muscles that decrease the size of the thoracic cage, and that would include your abdominals, right? Your rectus abdominis, external obliques, internal obliques, transverse abdominals. You guys have used all these when you practice doing pulmonary function testing, right? You have them take a deep breath in, and then you force that breath out as hard as you can if you're doing a forced vital capacity. Well, what muscles are you using during that procedure, right? If you were to do it right now, take a deep breath in and force it out, right? You're going to be using primarily a lot of your abdominal muscles, right? Those are all things that when contracted are going to decrease the thoracic size, right? Same thing with your lats, right? So when we're looking at this list, those are all important to see, okay, which ones increase the size of the thoracic cage and which one decreases the size of the thoracic cage. So if I have an issue where my abdominals, my abdomen, let's just say my abdomen was really, really big. I had ascites. I had a bunch of blood build up in my abdomen from a trauma. So what happens to the size of my thoracic cage? If my abdominal size increases, my thoracic cage must decrease. It gets restricted. It gets squished by the abdominal pressure, right? So what's going to be my ability to take a breath in? Now it's going to be a lot harder. So I'm going to need to use an accessory muscle of inhalation to overcome that increased abdominal pressure, right? So that's where I might see increased work of breathing. I might see my scalenes. I might see my sternocleidomastoids. I might see my traps moving there. I might see that tripoding, right? I might see that stuff trying to overcome that resistance to pulling gas in. Right. So here you see a picture, right? This includes on the left side of the picture here, you see your scalenes, your sternocleidomastoids, you see your external intercostals. You see all of these things here that allow for the chest wall and the ribs to expand. On the right here, you see the internal intercostals. You see abdominal muscles, right, that all help force gas out or push the rib cage closed or pull the rib cage closed when they are contracted. So those are all things that we're going to see when we're looking through all these different parts here, that it's important to know if these ones expand the rib cage and then which ones make the rib cage a lot smaller, right? And those are all things when you see accessory muscles in use. If I see a patient's sternocleidomastoids being used and they're on a ventilator, well, what are they having trouble doing? They're having trouble getting the breath in for some reason. They're still working hard to get that breath in. So even vented patient assessment really comes into also looking at their work of breathing while they're on the ventilator. If I see them using their abdominal muscles like crazy on a ventilator, well, that's probably trouble getting the breath out. And then I can look at correcting that with things like expiratory sensitivity, things that we'll talk about down the road. So when we're looking at this, we have spontaneous breathing, right? During spontaneous breathing, we have contraction of our inspiratory muscles, right? Our diaphragm, our external intercostal that causes the enlargement of our thoracic cage, right? So that's going to make the chest wall bigger, okay? According to Boyle's law, as the volume of a container increases, the pressure inside the container decreases, right? So as our rib cage expands, what happens to our pleural pressure and our alveolar pressure? If the volume of those containers are increasing, then the pressure inside our pleural space, the pressure inside our alveolar space decreases as our rib cage is expanding. So our alveolar pressure is going to become lower or subatmospheric pressure compared to the pressure at the mouth or at the nose or at the trach if we have a tracheostomy patient, right? So that's what's going to allow for gas to flow in because we have a pressure gradient. And the pressure gradient is just the difference in pressure between one side of a vessel to the other side of the vessel, right? And it always goes from a high pressure to a low pressure. So when we're inhaling, when our lungs are expanding because our rib cage is pulling open our lungs, our pleural pressure is pulling open our lungs, our alveolar pressure, our pleural pressure becomes more negative or subatmospheric, and that allows for gas to be pulled or sucked in because we have a higher atmospheric pressure than we do in our alveoli, and so gas can flow in. Conversely, right, when we have this issue where a person has a bunch of extra pressure left over, let's say they're air trapping or auto-peeping that we see with these emphysema patients, what's going to happen is that pleural pressure, can it become negative? Can that alveolar pressure become as negative if there's a lot of pressure still left over after the last exhalation? If there's still a lot of pressure left over after the last exhalation, they're going to have to work harder, right? Use more accessory muscles to pull open the lungs because they need more of that pressure gradient change. So that's what will increase that work of breathing. So when we're looking at gas flow, we're going to need to have that high pressure to low pressure gradient. And that's where we're using our pleural pressures, our alveolar pressures, to become subatmospheric during spontaneous breathing. Right? When we're exhaling, usually quiet exhalation is passive. We don't use accessory muscles for quiet exhalation, passive exhalation. However, we can use accessory muscles for forced exhalation, right? So when we're looking at exhalation, when we reach equilibrium at end inhalation where atmospheric pressure and alveolar pressure are equalized, and then what's going to happen? We're going to have the diaphragm stops contracting, the external intercostals stop contracting. What happens to rib cage? Right, rib cage decreases. And then according to Boyle's law, as the volume of a rib cage decreases, the pressure inside that container, the rib cage, right, that pressure inside the container, which would be our lungs in this case, increases. So that's what's going to allow for gas to have a higher pressure inside than what's in the atmosphere, right? And so then therefore we're going to exhale. It's that buildup of pressure from the recoil of the chest wall, from the chest wall coming back to its normal or smaller position, right? And so that's what's going to allow for that pressure gradient to reverse itself, where now I'm going to have a higher alveolar pressure than I do atmospheric, and that's going to allow for gas to flow out until I reach equilibrium, of course. So this is a quick animation, and I hope it helps out, where you see on that left, where you see the diaphragm contracting here. It's going to allow for that patient to expand the rib cage, and you see during inhalation that the diaphragm contracts and moves down, which allows for that expansion of inhalation and pulling gas in, because alveolar and pleural pressures are more negative, right? That drop in that negative pressure, and that's what we're seeing here, that alveolar pressure as the diaphragm contracts becomes more negative, which then pulls the lungs open. When the lungs pull open, alveolar pressure becomes negative and therefore sucks the gas in. The other advantage of spontaneous breathing, and this sort of bonus content, is what happens to the pressure in your vena cava as you're spontaneously breathing. Well, it also becomes negative. Thoracic pressure becomes negative during negative pressure breathing. And so the advantage here is I'm actually suctioning. I'm using a suction to pull venous blood in my vena cava, superior and inferior vena cava. I'm using that negative pressure there because just like airflow, it goes along a pressure gradient. So I'm actually pulling venous blood from my vena cava into my right atrium. So it actually helps with getting blood flow to the right side of the heart so we can get it to the lungs to oxygenate it too. So that's another cardiovascular advantage of negative pressure breathing, right? We don't see that with positive pressure breathing as much because we're pushing open the lungs from the inside. We're not suctioning, we're not creating negative thoracic pressure, and therefore, are we going to get as much venous blood flow flowing into the right side of the heart if we're using positive pressure, right? The odds are probably not, especially if we're using very high thoracic pressures. So something to think about there is also that cardiovascular component to spontaneous breathing. Now think about positive pressure and how that could impact, and why patients on positive pressure breathing might have more edema in their ankles and their legs. Well, that's because all this blood doesn't get suctioned into the thorax as easily, so it's going to pull, right? We're going to have more edema in our feet, our ankles, our hands, so on and so forth, because we don't have as much blood that's allowed to be pulled into that vena cava, right, with spontaneous negative pressure breathing. So something to think about there with side effects of mechanical ventilation. So spontaneous inhalation, we're going to have contraction of the inspiratory muscles, right? And you're going to see me try to use these visuals here to try to help give you that sort of functional picture, if you will. That contraction of your inspiratory muscles, which are primarily going to be your diaphragm and external intercostals, and this is going to cause, according to Boyle's law, that negative alveolar pressure because the pleural pressure become negative, and then therefore they suck open the lungs. As the lung volume increases, the pressure inside the alveoli decreases, and that's going to allow for that negative alveolar pressure. That negative alveolar pressure then becomes less than the pressure at the airway opening, and gas will flow in, right? We're using lower alveolar pressure. Of course, it uses that pressure gradient to suck gas in. When we exhale, we're going to reach equilibrium at end inhalation. And then when we exhale, we're going to have this relaxation. We're going to relax our inspiratory muscles, and that will cause a decrease in our thoracic volume. Well, of course, Boyle's law. As the volume of our lungs decrease, as the volume of the containers decrease, the pressure inside of a container increases. So therefore, my alveolar pressure will increase, and it will be above atmospheric pressure, and then I'll exhale. Gas will come out because it always goes from a gradient of high pressure to low pressure. And this is a picture directly from your book, and when we're looking at this, this is just showing and breaking down everything we've talked about. When we're breathing in, we're going to have a negative pressure, right? We're going to have this negative pleural pressure here. And when the diaphragm contracts, we're going to increase the space of that pleural space, which then creates more suction in the pleural space. That's going to suck open or pull open the alveoli. It's going to pull open the lung tissue. Once that does happen, then we're going to have less alveolar pressure than atmospheric pressure, and gas will be pulled in. Right? Conversely, when we relax, when the diaphragm moves up here, right? When the diaphragm is moving up here, we're going to have the diaphragm moving up, the pleural space becomes smaller, right? The alveoli, the respiratory zone, everything starts collapsing, and therefore the volume of our respiratory zone decreases. And so the pressure inside of our respiratory zone, as all those lung units decrease, is going to increase, right? And so that's where gas will go from a high pressure to low pressure and then come out, right? So this is just showing that shift in pleural pressure changes. Well, why is this an advantage to you? Well, this tells you, hey, if we have someone on mechanical ventilation and they have an auto PEEP issue or they have a lung compliance issue, which we'll talk about in the future, if we look at pleural pressure, which we can with an esophageal balloon, both for pulmonary function, outpatient, as well as on mechanical ventilation, if we use an esophageal balloon, well, the esophageal pressure is roughly equal to pleural pressure. And so we can see what pressure changes are happening and adjust mechanical ventilation pressures, like PEEP, or how much pressure stays in the ventilator at the end of a breath, based upon pleural pressures to optimize their lung units, to help reduce workload of breathing, to help reduce how much pressure it takes to expand the lungs, right? So these pressure changes do come in handy to view. Units of pressure, when we're looking at mechanical ventilation specifically, these units of pressure we're going to start at a baseline of 0. Even though at sea level we have 760 as our normal atmospheric pressure, right, at sea level, we're going to just start it at a baseline of 0. So what's our pressure change from the baseline? So that's why we assume 0. We're not starting it from 760, we're assuming from the baseline. So it's pretty much tearing a scale before you put something on it with a cup, right? So you're going to measure something in a chemistry lab, you put the cup on the scale and you zero it, and then you put the solution or powder in there, and then you put the cup back on the scale with that solution or powder or whatever you're trying to measure in there with it. So you're pretty much tearing the scale. You're just saying, okay, from a baseline of 0, what's our pressure change, right? So that's why it's a baseline of 0. When we're units of pressure for mechanical ventilation, primarily we're going to be using centimeters of water pressure. And what do you notice out of this list, right? If 1 millimeter of mercury is 1.36 centimeters of water pressure, well, that tells me I have more integers. I have more changes. It's a more sensitive value to use centimeters of water pressure than to use millimeters of mercury, right? You use millimeters of mercury for blood pressure. You use millimeters of mercury for suction pressure, right? But when we start talking about mechanical ventilation pressures, we're using centimeters of water pressure, right? Right, centimeters of water pressure, and that's going to be the big thing to pay attention to because it's a more sensitive pressure measurement than a millimeter of mercury or even a kilopascal. Look at kilopascal, 7.5 millimeters of mercury for 1 kilopascal, 1 kPa, right? So we're seeing that our lungs, especially our respiratory zone, very, very sensitive organs, right? Our alveoli are very sensitive and they're very prone to damage. So we're going to want to make sure that we have very small integers and very detailed sensitive integers to help avoid injury and trauma in these patients. And that's why we use, part of why we use centimeters of water pressure. You will see some in the respiratory community and in some studies do an interchange where 1 torr is 1 millimeter of mercury. So you'll see that equation. Torricelli is the guy that came up with the millimeter of mercury. So they considered it equal to each other. So if you see that on boards, or you see that in exam questions, they consider 1 torr equal to 1 millimeter of mercury. All right, pressures and gradients in the lungs. So this is where we're going to start talking about all these different airway pressures. And I know this picture over here looks a little too busy, but just break it down, take it one step at a time, right? Slow your brain down. Deep breathing, right? So there are a bunch of pressures involved with breathing, right? Airway opening pressure is the pressure here, whatever is at the mouth, right? The pressure of the airway opening. So it could be mouth pressure or airway pressure or upper airway pressure, right? Mask pressure if they're wearing a mask, right? Or proximal airway pressure if they're on mechanical ventilation or something like that's going on. So there are many terms here to look at airway opening pressure, all right? So that's one of those things where these are synonyms, they're just alternate ways to say this depending on what's going on with the patient. If I say, hey, their mouth pressure is this, well, that tells me probably they're spontaneously breathing. If I say, hey, their airway pressure or their mask pressure, right? They're on non-invasive ventilation, or their proximal airway pressure, or they're on positive pressure ventilation, right? So it depends on the scenario in which or the condition in which the patient is in. And that's where they're just synonyms to help with that. So don't get too caught up in those alternate synonyms for mouth pressure or airway opening pressure. When we're looking at pressure at the airway opening, there usually is 0 atmospheric pressure. This is what I was talking about earlier, where it's 0 at baseline, because we're looking at what's the change from the mouth pressure, right? So we're starting it at 0 at a baseline, even though we're starting at 760 millimeters of mercury if we're at sea level. But the big thing here is it starts at 0, right? Similar measurements is the pressure at the body surface area. So when we're doing this, we're assuming the whole body surface is at the same pressure as the mouth pressure. But what if we have someone in iron lung, right, where just their head's sticking out, right? The rest of it's all in a box, right? They're going to have a different body surface pressure compared to their mouth pressure or their airway opening pressure as well. So that's something that we're going to see there. So there's a bunch of these here. Just try to break it down, but understand they're synonyms and there's a reason why there's so many different terms because we have so many creative ways to ventilate. Right? Intrapleural pressure is going to be one of the ones that we start talking about here. This is a pretty vital one, especially when we look at conditions like pneumothoraces, pleural effusions, when we start looking at abdominal pressures from either third trimester pregnancy or ascites or ileuses and things like that. We're going to have to look at abdominal pressure playing a factor in not only negative pressure breathing, but positive pressure breathing as well. This is the pressure, pleural pressure is the pressure in the potential space between the parietal and the visceral pleura, right? Between the Parietal and visceral pleura. The parietal is the one on the inside of the rib cage. That's what it's like, the perimeter, right? The rib cage one. And the visceral is going to be the covering of the lung itself, right? The covering of the lung itself. This pressure, and I would pay attention to these, right? These numerical values here. End exhalation is usually about -5, because what happens with the pleural pressure at end exhalation? Well, if the pleural space is smaller at end exhalation, and if a smaller pleural space means a smaller pressure left over, a smaller subatmospheric pressure. If I'm inhaling, I have a much bigger pleural space. That means I'm going to have a bigger pressure, a bigger suction pressure, if you will, end inhalation, right? Because it's a bigger suction space. So that's why at end inhalation it's only 5. At end inhalation, it's about 10 centimeters of water. Right? Now, can we measure these at the bedside? Absolutely, right? That's what I was talking about earlier with an esophageal pressure balloon. This is something that some ventilators have an option where we can hook up an auxiliary transducer to the ventilator even and look at esophageal pressure and equate that to pleural pressure, right? And then we can see what's going on. Are they requiring a lot of pleural pressure changes? Well, if they are, then that tells us that we might have an issue with our compliance, and we might have to make adjustments with how much positive and expiratory pressure, how much we're using to ventilate that patient with. So these are all going to come in handy. So we love looking at different things there that can help us. Now, are we going to use an esophageal pressure balloon on all of our patients? No, but when we're trying to figure out or trying to do things like determine optimal positive and expiratory pressure, or look at different ways to keep the lungs recruited for different types of disease processes, that's where this can come in handy, right? So it will vary from facility to facility, but it's something to keep your eyes open about and understand that, hey, if we're thinking about a pleural space issue, we can always measure that, and it's just dropping an esophageal balloon and looking there at their esophageal pressures. When we look at alveolar pressure, so we just looked at pleural pressure, now we're looking at alveolar pressure, and this is another term for this is called intrapulmonary pressure or lung pressure. Intrapulmonary pressure or lung pressure. When we're looking at alveolar pressure, this is the one that primarily changes secondary to intrapleural pressure. So intrapleural pressure is your influencer, it's going to start it. And then as a result of intrapleural, then alveolar follows along. It's like the kid sister or kid brother, right? So you're going to have your alveolar pressure change. It's going to follow around whatever the pleural pressure does, right? If the pleural pressure is decreasing, right, and becoming more open, right, so we have more suction, then alveolar pressure is also going to decrease and be pulled open by that pleural pressure, right? So it's going to follow whatever the pleural space does. So alveolar is not the influence, it's pleural pressure that's the influencer. So it is the follow along person with it, right? It's the Robin to the Batman, right? It is whoever's following it around. So normal changes in pleural pressure, usually about 1 centimeter water during spontaneous breathing. That's it, right? That's it, just about 1 centimeter water pressure. So when we're exhaling, right, spontaneous exhalation, same thing. Usually just about 1 centimeter water. And that's all it should take to do normal, quiet, spontaneous breathing. However, now you add conditions like pulmonary fibrosis where the lungs are super stiff, or kyphoscoliosis where we're going to have a harder time expanding the chest wall and harder time getting more negative pleural pressures. That's where we're going to see a big difference. We're going to see a big gradient that we have to overcome, and that's where pleural pressures can increase. So as compliance decreases, we're going to have to increase the muscles of our chest wall and abdomen, right? We're going to have to increase the muscles of the chest wall to pull open the lungs. So that's where we might see some accessory muscles come into play as our compliance decreases. You have 4 basic pressure gradients when we're looking at this. Transairway pressure and transthoracic pressure are 2 that we'll start off with here. Transairway pressure is the difference between the mouth or pressure of the airway opening and the alveoli. So from here to here, right? It's the difference between the pressure at the mouth to the alveoli. So that's your transairway pressure. So why do you need to know about this? This is the big thing that represents how much gradient is required for airflow in the conducting airways, or how much airflow it needs to get from the mouth to the respiratory zone. That doesn't include the respiratory zone. It's just mouth to the respiratory zone, right? So how much pressure it needs to get there, right? So we need to overcome the resistance. Key point here, I'm going to put a star, right? Overcome the resistance to gas flow in the airways. So this means if I have someone that has a super small airway, let's say they have asthma, right? Let's say they have a massive inflammation in their lungs. They also have bronchospasm. That means the pressure it takes to get gas from their mouth to their alveoli is going to be pretty darn high. It's going to take a lot of pressure to go through those conducting airways just to get to the alveoli. So that means we're going to have almost an airway resistance issue, right? We're going to have an issue with bronchospasm. We have something going on with our conducting zone that's resisting gas going through those airways, right? So we're going to have a lot longer time to get gas into and out of those airways. It's when you have a traffic accident, what happens to the flow of traffic, right? It decreases. You're going to have a harder time getting through a 2-lane highway than a 5-lane highway, right? As the highway gets smaller, it's going to take longer to go through there, and it's going to be a lot more pressure. It's going to take a lot more energy to get gas to go there. And so that's why when we see patients with a severe asthma attack or severe COPD exacerbation on a ventilator, it's going to take a lot more pressure to get gas from their ET tube or their tracheostomy tube down to their alveoli. We might have someone that has a peak airway pressure of 50 centimeters of water, right? Super high airway pressures. But their plateau pressures, or how much is being represented by their alveoli, can still be low. And the issue is the tube that gets there, right? It's a smaller tube. It's small conducting airways. So transairway pressure, very important, very, very important. It doesn't involve alveolar pressure. So I can have a person with a high transairway pressure and still be protective to those little alveoli, right? And that's why we look at the different kinds of pressures when we put someone on a ventilator. Right? If I see an alveolar pressure that's 50, that's a bad sign, right? If I see someone at a peak airway pressure that's 50, but an alveolar pressure that's 20, then they still have lung protective ventilation at the alveolar level. The next one here is transthoracic pressure. Transthoracic pressure is the pressure between the alveolar space and the body surface area, right? So the pressure required to expand or contract the lungs and the chest. This is going to be one of the big ones that we look at with abdominal issues or chest wall issues, or even the negative pressure ventilators that are sucking the chest wall open at the body surface. So we're changing the body surface pressure that then suctions open the chest wall, that then decreases alveolar pressure and allows gas to flow in, and vice versa, right? So we're allowing that to happen. We're allowing that to flow in when we're changing that body surface pressure. So transthoracic pressure, the difference between the alveolar space and the body surface pressure. So that's what we're looking at here, alveolar to body surface. And that's going to be one that we can manipulate with artificial means as well when we're going through our different types of ventilators. The next two, right, this is 3 and 4, transpulmonary pressure. This is the difference between an alveolar space and the pleural space. So when we're looking at alveolar and pleural space, that's transpulmonary pressure. Alveolar and pleural space, right here. So this is what it takes to create that gradient between the lining of the lung pretty much and the pleural space. So when we're looking at this, how much pressure is required to maintain inflation. So the idea here is if I drop an esophageal balloon and I see low pleural pressures, as equated by esophageal pressures, if I see low pleural pressures, if I see a lot of changes there, then I know that it's going to take a lot of pressure to maintain alveolar inflation. So then I can adjust the ventilating pressure appropriately, and we can play around with this. But when we're looking at this, this is looking at pretty much distending pressure, right? This is the big thing you're looking at here, is that distending pressure. How much it takes to keep the alveoli recruited, how much it keeps to take alveoli open. And we can manipulate this with mean airway pressure, or how much pressure we leave in the ventilator at any given time, as well as how much we leave at end of exhalation. So this is something that we can optimize for our patients when we're looking at controlling the positive and expiratory pressure, or PEEP, and when we call it that, it's very similar to what we have with negative pressure breathing, or not negative pressure, with non-invasive ventilation with CPAP, right? So it helps us where we can titrate that. When we're looking at the last one here, transrespiratory pressure, this is the pressure difference between the airway opening and the body surface, right? So body surface and the airway opening. So this is the one right here, transrespiratory pressure. This is what we're looking at is very similar, very similar to what we were looking at earlier with some of our other ones. So this is how much it is required to inflate the lungs during positive pressure ventilation, right? How much it takes to open up the lungs during positive pressure. So very similar, transthoracic and trans airway pressure are very similar, right? These are pretty much cousins, right? Transthoracic and trans airway pressure. So you'll usually see those. A lot of people will use them interchangeably. Are they identical? No, but you'll see people use them interchangeably. Doesn't mean it's right, but you'll see a lot of similarities. So now we've gotten to lung characteristics, and hopefully you're still with me here, but when we're looking at compliance, it's how easily, right, the structure distends, or how easy it is to expand, right? So this is how easy it is to stretch. In the clinical setting, it describes the elastic forces that oppose lung inflation. So if I have a really brand new, super tiny, highly elastic balloon, and I'm trying to blow it up, is it easy or hard to blow up if I have a brand new, tiny elastic balloon? Well, it's going to be hard, right? Because it has a lot of elastic forces, right? It has a lot of elastic forces to blow up that balloon. So that balloon has very low compliance to begin with because it has high elasticity, right? It has low compliance because it has high elasticity. Now, if I take that same balloon and I stretch it, and I'm stretching that like crazy. I want to blow up this balloon super easy, so I look really cool and blowing a balloon, right, without struggling. And then I blow into it. What happened to the elasticity of that balloon? Well, I decreased the elasticity. And what happened is it's an increased compliance because, hey, it accepts volume very easily now, where it didn't accept volume easily before. So where I'm accepting volume easily without any resistance, well, that's high compliance, right? That's very high compliance and low elasticity. So if I have someone with just baseline emphysema, we're not talking about air trapping here, but baseline emphysema, they have very high compliance. Their lungs are stretched out, right? They can expand very easily, but their elastance is very low. So when they go to exhale, how well are their lungs going to exit gas out of their lungs? Are they going to have that recoil that helps gas get out of their lungs? No, it's not going to be as easy to get gas out of their lungs because their lungs have been stretched out. It's that balloon that has been stretched out. So they have high compliance and low elasticity, right? So these are inverse of each other. If I have high compliance, I have low elasticity. And then the inverse is true. If I have low compliance, like stiff pneumonia lungs, then I have very high elasticity, right? So with a pneumonia patient, it's going to be very hard to expand their lungs. But when they go to exhale, they're going to close very quickly. Over here, I have a patient with emphysema, and their compliance is, they go to inhale, they're going to accept the tidal volume very easily. It's going to hardly take any pressure to deliver that breath. But when they go to exhale, they're going to have hardly any elasticity, which is going to make it harder for them to exhale, which means I'm going to have to make sure they have a long enough time to exhale. So compliance and elastance are inverse of each other. So compliance is how easy it is to stretch open. Elastance is its snap shut, right? Tendency to return to its original form. Right, that's what you see. And they oppose compliance. So if I give you a scenario, I say, hey, a patient has pulmonary fibrosis, right? All right, so I know that's very stiff lungs, so I know that their compliance is going to be decreased, but their elastance will be increased. So if that person is breathing faster on a ventilator, are they likely to air trap? Not as likely, right? If I have someone that has an asthma exacerbation, right? And their compliance, or let's say a COPD exacerbation, and their compliance is increased, right? Am I going to want that patient to breathe really, really fast on that ventilator? Am I going to set a really fast breathing rate for that person? No, because they need that time to exhale because their elastance has decreased. So they're inverse of each other, right? If I have a decreased compliance, like what I see with with pneumonia, then I'm going to have high elastance. And if I have high compliance, I'm going to have low elastance. So compliance in the clinical setting, big thing here is we're measuring the change in volume that occurs when we're applying pressure. So we're going to have the change in volume over the change in pressure, and that's the basic lung compliance calculation. Just the change in volume over the change in pressure. So when we're traditionally set up most adult patients on ventilation, we're going to have a set volume. So primarily one of the things that we're going to be looking at is the change in pressure when that patient is getting a breath delivered, right? That change in pressure can tell us about lung compliance. It'll give us a good indication about what's going on with that patient's disease process. And so we're looking at change in volume over change in pressure. When we look at normal compliance, you do need to know this for a spontaneously breathing person. It could be anywhere from 50 mLs to 170 mLs per centimeter of water, right? 50 to 170 mLs per centimeter of water, right? That's a normal spontaneous lung compliance. However, if we use positive pressure breathing, right? Because this up here is negative pressure breathing, right? When we go over here to positive pressure breathing, there's a big change, right? This is going to be a lot lower lung compliance. Do you not see that, right? A lot lower lung compliance. Why is that? Well, when we're intubating, we're pushing things out of the airway, right? We're pushing the lungs open. We're pushing the diaphragm down. We're pushing the chest wall open. We're pushing the abdomen out of the way. See how it's a little bit more violent in that aspect, right? So we're pushing things out of the way. So is it going to expand as easily? Do we have a nice pulling expansion, or do we have to push things out of the way? Well, we have to push things out of the way, and therefore it's not going to expand as easily because we have to force it out of the way. We have to force it out of the way. And that's why intubated lung compliance, normal is going to be about 40 to 50 or 35 to 45, depending on what's going on with their rib cage when we're looking at this. So that's one thing that we have to be cognizant of when we start doing mechanical ventilation is, yes, these are numbers up here with spontaneous breathing that you had to know with previous courses. However, with positive pressure ventilation, because the physiology changes, right? We're not using negative pressure anymore. We're using positive pressure. That also changes our normals, right? The physics changes it, right? The physiology changes it. All right, so let's do a clinical application. You have a patient, Mr. Anakin Skywalker, with severe abdominal thoracic burns. His care team notes an increase in oxygen requirements while he's on the ventilator. Okay, so he's gone up on his oxygen needs. You note an increase in the pressure it takes to deliver his set tidal volume. So he's on volume targeted or volume controlled ventilation, and it takes more pressure now, right? It takes more pressure to deliver that volume, right? So now I'm thinking about what does that mean for him, right? Is that a good sign or a bad sign that it takes more pressure to get his same tidal volume in, right? That's what I'm thinking about. His chest X-ray shows maybe some atelectasis, but otherwise pretty clear. So nothing new going on besides his lungs are smaller, right? Mr. Skywalker has no changes otherwise. So what's going on? What's happening with this lung, thoracic, abdominal compliance? Is it very easy for them to expand with that same tidal volume breath, or is it very hard for them to expand? Well, if pressure is increasing, that means most likely our compliance is decreasing. So if I walk into the room, it could be one of two things. It could be compliance, airway resistance, or both, right? But just let's start with compliance to begin with. If I see it takes more pressure, then it could be his lungs, his chest wall, his abdomen are getting stiffer, right? And with someone that has severe burns, especially if is it possible for those burns to restrict the movement of the abdomen, to restrict the movement of the chest wall? If those burns are restricting the movement of those, then we're going to see it's going to be a lot harder to deliver the breath. So the ventilator is going to have to use more pressure to deliver that same volume, right? So his compliance would be decreasing, right? It's a lot harder to blow up the balloon of his lungs, right? A lot harder to blow up his balloon of his lungs. So what happened with his elastance? Well, if compliance decreased, elastance increased, of course. All right, it's been 4 hours later. You check on Mr. Skywalker and note after the fasciotomy, right, where they open up those burns, his saturations have improved, and there's less pressure it takes to deliver his tidal volume. No changes otherwise were noted. So when we're looking at it now there's less pressure, right, to deliver that same tidal volume breath. That didn't change. The only thing that changed is it took less pressure. So what happened with his lung, abdomen, and chest wall compliance, right? With his lung, abdomen, and chest wall compliance, they started improving, right? So it took less pressure, and that was a sign that, hey, it could be lung compliance. They could be improving, because now, do we have as much restricting his ability for those to expand, right? Because when they're on a ventilator, you have to push those things out of the way, right? Well, just like we talked about before. So now what's going to happen with this patient? Well, their compliance has improved, right? So that means there's probably less atelectasis. There's probably more surface area, right? Which help his saturations. So his compliance improved. Would this represent a change in elastic or frictional forces? Well, we just talked about elasticity. When you have that resistance to expansion, that's a high elasticity. When it's easy to expand, you have low elasticity. When it's hard to expand, you have high elasticity. So that's something that we see here. It's a change in the elastic forces to breathe. Since the lungs are moving continuously, we must pause the breath after it's delivered to look at lung compliance. And so you're going to see this, and we'll highlight it in lab as an inspiratory pause or inspiratory hold, or it's some version of that wording on the ventilator, right? We're going to tell it to do an inspiratory hold. Some of them will do it automatically, periodically too, just depends on the manufacturer. And we're going to tell it to do a breath hold. Because what happens as we're breathing in, as we're breathing out, we're going to have changes in how compliant or open our lungs are. So what happens here is we need to do it. Okay, it takes a lot of pressure to deliver the breath. We just talked about the pressure it takes to deliver a breath. How do I know what part of that cycle, what part of that inspiratory pressure is actually representing his true compliance? Well, I don't. But if I pause the breath after it's been delivered, right before exhalation, right? Inspiratory pause, right? The breath has been delivered, pause, right? Hold it there. Then I'm going to see what happens when everything is relaxed. I'm going to see what the back pressure is of the alveoli, what the elastic recoil, if you will. Elastic recoil of the alveoli. So that's why I need to do an inspiratory pause, right? To look at the elastic recoil. What that elastic recoil tells me about lung compliance, right? So if I have high elastic recoil, I know my lung compliance is decreased. So if I have a high plateau pressure or high inspiratory pause pressure, then I know I have a decreased compliance. If I have a low plateau pressure, then I know that their compliance has increased, right? Because I'm just seeing what is my elasticity of the respiratory zone, right? If my elasticity is very high, then I know my compliance is very low, and it could be something going on. Their pneumonia is getting worse, right? Something like that, or they have a pleural effusion that's getting worse. Something's getting worse and making it harder for them to breathe. So patients on mechanical ventilation, when we do lung compliance measurements, we try to do it during static conditions, right? So you're going to see there's two things called static and dynamic compliance. But for now, we'll just talk about static compliance. Static compliance, the equation is we're going to take their exhale tidal volume, and then we're going to take their plateau pressure, right? That's where we get that expiratory pressure. And we're going to subtract it from the end expiratory pressure, or the PEEP level, if you will. And so that tells us without PEEP, without that positive end expiratory pressure, without that total pressure left over that we're letting the ventilators keep in there just to keep their lungs distended with positive pressure, we want to see what their lung compliance is without gas moving. Right? We want to see what their lung compliance is just in their respiratory zone. So this one's going to evaluate pretty much our respiratory zone compliance, right? We're looking at how healthy the alveolar walls are, right? Is the alveolar getting more stiff? Are we having an issue where we're getting more fibrotic or inflamed? Or are we having an issue where we're actually getting better, right? Our compliance is steadily improving. So that's why we do that inspiratory pause maneuver to get a static lung compliance. We're going to pause after the breath has been delivered. We press a little button and it does a little small breath hold, and it allows for us to measure the recoil of the respiratory zone, which tells us about alveolar health, about plateau pressure. And we usually try to keep this plateau pressure 30 or below, right? 30 or below, 30 centimeters of water, right? We use centimeters of water here, or below. When we're looking at the ventilator graphics, we can sort of see why we use a plateau pressure versus using how much total pressure it takes. So here, when we deliver a breath, here's the breath being delivered, and that's that peak inspiratory pressure, right? That's how much pressure it takes to deliver that breath, right? And that's where it has to overcome pushing the lungs out of the way, pushing the rib cage out of the way, pushing the abdomen out of the way, pushing all that stuff out of the way. And so it's going to take a lot more pressure to expand the lungs than it is to keep the alveoli open, right? So that's why you see this big gradient between how much pressure it takes total versus how much elastic pressure there is. And that's why we have to do a plateau pressure here to sort of see what's going on with our respiratory zone, right? Are we getting worse with inflammation? Are we getting worse with what's going on in the respiratory zone? Or is the respiratory zone trending better, right? And that's why we do that pause. So we do that plateau pressure pause. And that's going to help us overall. So when we see an increased issue with our plateau pressures, that means we have increased elasticity, which means our compliance decreased. Our next phase that we're going to talk about here is airway resistance. So airway resistance is going to be the frictional forces of gas going into your lungs and out of your lungs, right? So the frictional, we just talked about the elastic forces, and now we're talking about the frictional forces. And this is gas flow and resistance where we have the change in pressure over the flow rate. The change in pressure over the flow rate. You remember us doing this equation earlier on in the program. So change in pressure over the flow rate, right? So we're looking at the pressure change over how the flow of the gas. A normal unintubated patient is going to be a lot lower, but now we're going to stick a tube in here, right? What happens when you have a smaller tube than what your oral pharynx is, right? Yeah, your ET tube, your trach tube, they're smaller, right? And so you're going to have an increase in your airway resistance, right? So an intubated patient's airway resistance is just like we talked about with compliance, where the compliance decreases with positive pressure ventilation. Whenever we intubate or trach or have an artificial airway in someone, their airway resistance increases as well because we have a much smaller tube they're breathing through, right? Your mouth is a lot bigger tube than an ET tube traditionally. So that's why RA increases, and that's that frictional forces to get gas into and out of the conducting airways. right? So if we have a patient that's unintubated emphysema in asthmatic patients, they could have anywhere between 13 and 18 centimeters of water per liter per second. That could be that high just at baseline without positive pressure. So now we put them on a ventilator. Let's say we put any of these disease conditions on the ventilator. What happens to that frictional force it takes to get gas through those small or obstructed conducting airways? Well, it's going to increase. We're going to have a higher raw the more these airways become narrow, right? And so that's going to be an increase there. So resistance, what are some things that can cause that? Well, as far as disease conditions go, right, tissue resistance is something that we got to look at here. Accumulation of fluid is going to be one thing. So if we have a bunch of edema that happens from whether it's cardiogenic or pulmonary edema, or if it's something where you're creating lots of secretions, that can increase the resistance of gas going through a much smaller radius, right? A much smaller radius of a tube than compared to a nice open airway here, right? A nice open one. So when we're looking at this, something like secretions or fluid buildup can easily cause that resistance to decrease. What if they're biting down on their ET tube? What if they have a mucus plug? What if they have anything else that's causing their airways to get smaller is all where we're looking at here to increase their airway resistance. Airflow to resistance includes the viscosity of the gas. So this traditionally is not something we change too much for our purposes with mechanical ventilation. The density of the gas, that we can change. An example of that would be heliox, right? If we're changing the density of the gas, then that can change the airflow or the resistance of gas going through the tube. So even though this tube up here is smaller, if I change it to a less dense gas, a gas that can have less turbulence with it being delivered because it's so light, uh, that it can actually flow a lot easier into and out of their lungs and help with gas delivery into and gas exiting their lungs as well, right? So that'd be an example of a density of gas changing, right? The flow of the gas through the tube. If I have a super fast gas, if I have a very turbulent flow and I'm sending it through a tube, well, I'm going to have more resistance. But if I decrease the speed of that gas being delivered through that tube, right? If you have a hose and you turn it on super high and you keep turning it up super high, what's going to happen to the pressure or the resistance that's going through there? Well, you're going to see more turbulent water coming out of the end of that hose. Well, what happens if you decrease the water pressure to the hose? Well, you're going to see the water become more laminar. It's going to flow easier out of that end of the hose, right? So once you see that water flow easier out of there, then you're going to see, okay, so the flow rate can also make a difference. So if I take a person on a ventilator and I give them a super high flow rate to deliver a tidal volume breath, really fast breath, right? What can happen to the characteristics of that gas? Well, it can become very turbulent and cause air trapping, right? So I gotta watch out. There can be a point where you can cause that turbulence to happen and therefore have a bad effect on those patients. So we gotta be careful. The other thing here is if I turn down the flow rate ever so slightly, right, I can make that flow rate become a little bit more laminar, right, and I might get a change where I have gas being delivered into and out of the lungs a lot easier as well. So this is something you have to pay attention to. There is a point where you can make gas flow too fast, right, especially if they have a smaller airway. Airway resistance is not easily measured. So what we usually have to do, and this brings into our terminology from earlier, is look at trans airway pressure, the pressure difference between pretty much the airway opening or pressure between the mouth, which in this is going to be the peak inspiratory pressure, right, at the ventilator, and then what's it at the alveolar level. So PIP minus plat. And that's where we were looking at in one of the previous slides where I showed that graphic, where it showed a change in compliance versus a change in resistance. When we see this, if I have my pressure it takes to deliver a breath increasing, well, that means if I have a bucket here and I have a tube, right, this goes back to the whole straw thing. All right, I have this tube and I'm sucking out the milkshake, right? I'm drinking a nice milkshake. It's nice, right? And it's a nice big straw. I'm going to flow really easily, right? I'm going to have a nice, easy time drinking that milkshake. However, I have that same milkshake, but now I have a much tinier straw. Then I'm going to need more pressure to drink that milkshake. The milkshake volume didn't change, right? Nothing in the cup changed. The only thing that changed is the radius of that straw, right? And so when that radius of that straw becomes smaller, then it's going to take more pressure on my part to drink the milkshake, right? That doesn't help my experience, right? So if I have to take more pressure to drink that, then that's what we see on the ventilator, right? If it takes more pressure to deliver a breath, but nothing changed with their alveolar pressure, so think about this as their alveolar pressure, right? If their alveolar pressure didn't change, right? Alveolar pressure stayed the same, so plateau pressure stayed the same, then what did we have? We had a change in our radius. We had a change in airway resistance. Another analogy that I like to put in here is with compliance and resistance. Hey, with the compliant relationship, both my PIP and plateau PIP and plateau, they go everywhere together in a compliant relationship. They go play tennis together. They go see movies together. They do everything. They're compliant. They hold hands, right? They hold hands. Imagine them holding hands. So my PIP, my peak pressure, and my plateau pressure, they move equally together. If my PIP goes up, so does my plateau. If my PIP goes down, my plateau also goes down. They love that relationship. It's a very compliant relationship, right? So if you see PIP and plateau move together, then that means it's a compliance change. However, if PIP changes and plateau stays the same, that means it's a very raw relationship, right? That means there's not communicating, they're not doing things together, right? So if my PIP increases, if I have a PIP that goes from 25 to 30 centimeters of water, but my plateau stays the same at, I don't know, 20, right? If I have a plateau of 20, and it doesn't change, it just stays at 20. Well, my PIP moved, my plateau stayed the same, so therefore it was a raw issue. So it's something to do with the straw, right? Think raw, think straw, right? Smaller straw, right? That's what we're looking at here. So if the PIP moves but the plateau stays the same, right? Then it's a raw relationship. They weren't very compliant. One moved, the other one stayed at home, right? It's a raw relationship. So what we're looking at here is it looks at how much pressure is delivered to the airways and how much to the alveoli when we're looking at airway resistance. So what would a change in raw be? A change in elastic or frictional forces? Well, of course, we just talked about this. A change in raw is a change in the straw, right? It's a change in the size of that diameter or radius of the airway, sorry. Radius of the airway. So this would be a frictional change. If there's more frictional force to drink through a smaller straw. There's more frictional force to deliver gas through a smaller airway, whether you're exhaling or inhaling. All right, so here's an example of an increased air resistance. If we set the flow on the ventilator to 60 liters per minute, and we have a PIP of 40, right? So that's how much pressure it takes to deliver the breath, right? So now I have a plateau pressure at 25, right? And I have a trans-airway pressure of 15. So how do I calculate this? I'm going to take my PIP minus my plateau, right? PIP minus my plateau, and that's going to tell me what change of pressure there is, right? So this is still change of pressure over change in flow. It just looks very fancy, right? Change in pressure over change in flow. There's the dot over it, right? So it's still the change in pressure over the change in flow. We just subtracted that gradient between the PIP and the plateau out of it. That's all we did, right? So this would be 15 centimeters of water per liter per second, right? So that would be something that we'd see there, right? Do you have to change, right, in flow in liters per minute to liters per second? Pretty straightforward there. We practiced this in the past as well. All right, let's look at an example. Right? You are working in a critical care unit, ventilator's alarm going off, and your patient is Mike Tyson, right? Brain injury resulted from inability to protect his airway. They intubated him. He's on mechanical ventilation. Ventilator alarm is allowing, right? Takes a lot of pressure to deliver his tidal volume. So right now you're thinking this could either be a compliance or a raw issue. We have to see what happened, right? So when we're looking at this, he doesn't look too good, right? He looks anxious. He's diaphoretic, right? His lung sounds are distant, so he's not getting good air entry into his lungs. So that could either be compliance or raw as well, right? No secretions, so we ruled out that factor, right? His abdomen is soft to palpation because we're looking at thoracic and abdomen compliance, right? And then we look at his vital signs. He has a little distress going on here. Um, we go ahead and grab some things. We see this is his chest x-ray. Nothing really abnormal here. The tube is in good position, right? It's right above the carina here. We see decent expansion, or if not a little bit low expansion of the lungs, but nothing to indicate a bunch of mucus plugging or air trapping or like that. Right now he has a tidal volume of 510 and a flow rate of 75 liters per minute. So his PIP is at 16 and his compliance is at 57 when we seen him earlier. Now his PIP is at 35, so his PIP went up and his compliance is at 57 still. So his plateau pressure stayed the same, but his peak airway pressure increased. So that tells you this is a raw relationship. So his compliance stayed the same, but his air resistance increased. And in this case, the big thing here would have been him biting down on his ET tube because he was so anxious, right? So that's something to look at, where it could be an decreased gas delivery to the lungs, where the PIP goes up. But when we're looking at this, the PIP increases. The plateau stayed the same. Therefore, it was a raw relationship or a raw change that happened. So now I think about what caused the diameter, what caused the tube to get smaller, right? What caused that tube to have more issues, right? Then we see another person right here. We're working in the ED. We have a man come in with a difficulty breathing, right? Recurrent pulmonary infections. He has 3 to 4 word dyspnea. He's having trouble catching his breath. Is diaphoretic. He's anxious. He's working hard to breathe, so you see accessory muscles going on. He has a history of COPD. He doesn't even know what that means, so odds are his disease management is not the strongest, right? He's wheezy, right? And he has a little bit of physiologic distress going on. All right, on X-ray, what do you see on X-ray? On X-ray, he had air trapping, right? And you see an arterial blood gas. Sure enough, he's a little hypercarbic, but he's actually alkalotic on that blood gas, right? So his baseline CO2 is actually higher than what we see there. So he's actually a chronic CO2 retainer, and he's hyperventilating currently, which is probably what's causing his air trapping. So we go ahead and give him a bronchodilator, right? And after the nebulizer has really kicked in, he's not wheezing as much. His accessory muscle use goes down. He looks a lot more calm there, right? And you see vital signs change as well. So his big thing here was a COPD exacerbation that led to that air trapping, right? He felt lightheaded because he had trouble getting oxygen into there. The nebulizer helped him because it increased the radius of his airways. He had improvement in airflow into and out of his lungs, which helped him feel better. With his lung compliance and emphysema, usually you're going to have low elastance, which means you have high compliance, right? What happens to elastance and emphysema? It's usually decreased, right? What does tachypnea and time constants have to do with this? Well, if he's breathing fast, what happens to his elastance if he's not able to exhale all of his gas, right? It traps gas in there, right? Gas stays in there because he's starting to breathe before the last of his last breath got out. So he's going to have that air trapping. right? If he has an IDE ratio, and this is where we'll look at this with mechanical ventilation, we talked about a normal IDE ratio is 1 to 2 for normal pathophysiology. But when you get into these discussions, and that's where we're going to time constants next, is when we get to somewhere that needs a longer time constant, whether it's an increase in resistance or a increased in compliance as well, right? So with him, not only with emphysema do you have floppy airways, which make it really narrow, right? Hard to get gas into and out of, but also what happens to the size of their bucket, right? The size of the bucket increases. So because the size of their bucket increases and they have floppy airways, it's going to take a long time to get all the gas out of their bucket, right? A long time to get gas out of the airways because they lost that elasticity, and they have a narrow straw to get that out of there. So it's going to take a long time for him to exhale. So if he's breathing fast, that's a bad thing. That's where pursed lip breathing can help these patients, right? Where it can help expand the back pressure that they're breathing, they're creating themselves, helps expand and stent open their airways so they can empty their big bucket, right? They can empty it a lot easier. So an IDE ratio that's a lot longer, like a 1 to 3, 1 to 4, 1 to 5, might be more appropriate for a person with this condition. And we can do this with mechanical ventilation where we can target a longer IDE ratio. And with auto PEEP, right, we're going to have a lot of back pressure that builds up. So we need to help decrease that, because what happened when he was able to get gas out of his lungs after we gave him the bronchodilator, right? His work of breathing decreased. That means he's not working as hard to expand his pleural space, right? And therefore it decreased his work of breathing once we took that workload off, right? So I want you to try to pause the video and answer these questions on your own. These are the challenge questions. These are the questions at the end of your chapter in the Pillbeam book. So I want you to pause, give yourself a chance to do that productive struggle and see if you can fill these in just by reading them. So the first one here, we're looking at spontaneous ventilation is accomplished by contraction of the muscles of inspiration, which causes expansion of the chest cavity, right? So this is what allows us to pull air in, because as the volume of a container increases, according to Boyle's law, the pressure inside the container decreases, which allows for us to pull gas into our lungs. And then, of course, the opposite happens when we exhale. The pressure as the thoracic cage decreases in size, so do the lungs, and therefore the alveolar pressure increases above atmospheric, and we exhale. So during mechanical ventilation, the ventilator provides some or all of the energy required to expand the thorax. This is a big point because this means that we should still evaluate patients for work of breathing if they've had muscle fatigue before mechanical ventilation. That's why knowing why a patient's on a ventilator is going to be very important, because if they're on a ventilator and they went through fatigue previously and they're still working hard on a ventilator, you still see those accessory muscle use. Are they going through muscle recovery? Are we allowing those muscles to recover from fatigue or not, right? And that's why it's important to note, is my patient still working hard to breathe? Right? Should this patient still be working hard to breathe even if they're on a ventilator, right? Those are questions that you're going to have to answer. And that's a big important part if we're looking at days on the ventilator and recovery and allowing those muscles to recover. Imagine running a marathon and the next day having to run another marathon. No, those muscles need to recover. And so that's why it's still important to look at these patients. All right. Two forces that oppose inflation of the lungs. Well, we have the elastic forces, which is what you look at with compliance, and our frictional forces, which is what you equate with resistance, right? So when we look at elastance, we're thinking of lung compliance, like pneumonia, where it's low lung compliance, right? And or high resistance, like we see with asthma or something like that, would be a frictional force. Besides the elastance of the lungs, what other elastic force will make it hard for the lungs to expand, right? Besides the elastic forces, what other makes it hard for the lungs to expand? Well, frictional, right? It's going to be hard for the lungs to expand, right? So it's going to be hard for the chest wall compliance, the abdomen compliance, right, to expand. What force is described as the result of the resistance of the tissues and organs as they become displaced during breathing, so positive pressure ventilation, and gas to flow through the airways, right? This is going to be your frictional force, right? So your frictional force is going to be that gas to flow through the airways, which is increased with airway resistance, right? That's what makes it hard, or high pressures on those patients. All right, compliance describes what type of forces? Elastic forces that oppose lung inflation, right? So if I have someone with pneumonia, very small, or pulmonary fibrosis, right, there's going to be a lot of force that is going to have to happen to expand that balloon, right? It's a new balloon that no one stretched out, right? It's going to be very hard to expand. It's going to take a lot of pressure to expand it, right? Airway resistance measures the frictional force that must be overcome during breathing. So that's why we like to look, there's a bunch of reasons why we like to look at both of these values, but compliance and resistance, you're going to see, are very important to trend when we're looking at these patients that are on mechanical ventilation. The next one, resistance to airflow through the conductive airways, depends on the gas viscosity, the gas density, the length and diameter of the tube, and the flow rate of gas through the tube, right? So we're seeing there's a bunch of factors that can be manipulated here, whether it's using a different density of gas or using a different size of a tube. Those are all things that we can do, or changing the flow rate. And that's going to be one of our keys that we can use to help with laminar versus turbulent flow rates. All right, so these case studies are just meant to sort of help bring some. So you have a person that you have, Mr. Anakin Skywalker is coming in. He is on non-invasive ventilation, right? He's wearing a helmet, non-invasive ventilation. He has breathing assistance there. He hopes that you can help with his lung force, right? So he has a lot of pulmonary infections. He has some history of trouble catching his breath, chasing after his rebellious children, for sure. Pretty stable guy, currently on 40% oxygen. All right, what do you see with that blood gas? He has a chronic CO2 retainer, right? You can see that he, on 40% oxygen, he's still got uncorrected hypoxemia, and he's as a normal pH with a CO2 in the 60s. So he's definitely got a history of lung issues. And so when we put someone on mechanical ventilation, even someone like this that has a history of lung issues, are we going to be aiming for a CO2 of 40 every time, right? Would that be appropriate to aim for a CO2 of 40 when his baseline is somewhere in the 60s? Right? That wouldn't be appropriate. That's not his physiologic baseline. And so a lot of what we do is need to make sure, even though it would look really pretty to have a CO2 of 40, we need to make sure that we bring it to whatever their baseline, close to whatever their baseline may be. All right, so what do we see on his pulmonary function test? Well, they do a DLCO on him. And why do I bring up the DLCO in mechanical ventilation? A, I would think it would be cool to have that feature with mechanical ventilator, but B, when we look at diffusion with DLCO, and is there a way, this is bringing up an extra credit, not credit, but an extra bonus content for you, is there a way that we could figure out someone's diffusion with mechanical ventilation? Well, there might be an equation like the PF ratio, right? The PF ratio, we're looking at the P little AO2 versus their FiO2, and we're trying to see how easy it is to get oxygen from the alveoli, FiO2, into their artery, P little AO2. So how easy or hard is it to get in there, right? The higher the value on this, the better. The easier it is to get diffusion in there. The lower the value, the harder it is to get diffusion in there. And so you'll see a lot of times at the bedside, how do we look at diffusion? Well, one of the ways that they look at diffusion, you can look at your A to A gradient, right? P big A minus P little a. You could look at your A to A ratio, little a over big A, or you can look at your PF ratio. All three of those will tell you about diffusion across the alveolar capillary membrane, right? And so that helps tell you about what's going on with their disease process. Is their diffusion getting better? Is their diffusion getting worse? So yes, in PFT world, we have the DLCO that can give us that numerical value if their diffusion's getting better or worse. But at the bedside, we also have things we can calculate to see if their perfusion is getting better or worse. Hey, he has a pressure change of 20 centimeters of water with a tidal volume of 500 mLs. What's his lung compliance? Right? So now you're going to have to calculate that. I won't give it to you here. He's 80 liters per minute on his flow rate, and the change of pressure is 20. What's his raw, right? And remember, raw needs to be in liters per second. So 80 over 60, right, to turn it into liters per second. And then we have the change of pressure of 20. So we're going to have a raw that's probably pretty high, is my guess. So what type of disease process does he have going on? Well, odds are it's a combined issue with him. Not only does he have poor compliance, but he has high airway resistance. He has a pretty extensive pulmonary history, and he's having a lot of trouble when he breathes just baseline. So he's going to have trouble breathing in and breathing out traditionally. His lung compliance was decreased. His airway resistance was increased. His lung volumes were low. His flow rates, his diffusion was poor, right? And so should we make any changes with him? If he was uncorrected hypoxemia, we need to go up on his FiO2. Well, there's something we have to look at there with if he's on, what if he's on 60% oxygen, right? Maybe we have to consider going up on the pressure because he might have refractory hypoxemia. So that's something that we'll have to tackle, and we'll talk more about that in the course. We got a new patient. He's being transferred to your critical care unit. He's on a ventilator, right? He's in respiratory distress. He's on a ventilator, and he was in respiratory distress. Ask you to treat this patient. He's on a ventilator with a set tidal volume of 420 milliliters and a flow of 60 liters per minute. He gets 430 mLs back on average, so that's how much exhaled tidal volume he has. So inhaled is 420, exhaled is 430. So this is normal, right? Because what happens as you exhale, pressure and volume vary inversely. You're going to have less expiratory pressure than inspiratory pressure. So according to Boyle's law, your exhaled volumes might be a little bit bigger than inhaled volumes. All right, it takes the ventilator 15 centimeters of water to deliver the breath. What's his lung compliance? So then I'm going to have you guys calculate his compliance and his airway resistance. And you can pause here and calculate those. All right, he is sweaty, he has accessory muscles, significant smoking history, so COPD, lung cancer, these are big things. Cardiac history as well. Sputum, you don't hear any sputum in there when you're auscultating, and you just diminish breath sounds. Vital signs, he's not the healthiest one. He's on 90% saturation on 70% oxygen, and he's not picking up his pulse ox very easily. So let's look at his ABG, 730, so it's the acidosis, CO2 is 60, and his biocarb's 32. So once again, we probably have someone that's also a chronic CO2 retainer, and now they're still retaining a lot of CO2 currently, right? The PO2 is good, it's above 60, so 87%. So his PO2 is good, but his saturation probably around baseline, but 70% oxygen is quite a bit. So his diffusion right now is very, very poor. Well, why is his diffusion poor? Well, did he have a compliance issue, a raw issue? Does he have both? And this is his check sticks, right? What do you notice about this whole lung section over here, right? He has a massive pleural effusion that's restricting his lungs. Now here you can see the emphysematous lung changes that's going on with this person, hyperexpanded. But over here, what's going to happen to his lung compliance, right? His lung compliance is going to decrease. His elastance, therefore, would increase, right? And then what happens to the pressure it takes to deliver the breath? Well, that would increase. And gas goes the path of least resistance. So when the gas is delivered, instead of going up into this lung over here, we're going down into this lung over here and hyperexpanding, which is bad for that lung. So the big thing here, it's a restrictive pathology that we're seeing with this patient. He does have obstructive issues going on too with his baseline, but his big thing is going to be that restriction. So one of the things that they'll have to do is call the thoracentesis and drain that or put in a chest tube. And that will help with his oxygen requirements. That will help with his lung compliance, right? Even though he had that baseline emphysema lung cancer, that's going to help his compliance. All right, and then this is the chart. This is done by the National Institute of Health. And you might see these on some RT's badges or something very similar to that. There's something similar in your Oaks books as well that help you if you have a patient that comes in and you want to start someone on a tidal volume of 6 mLs per kilo and they're 5'5", then you know that we're going to start around 340 mLs for their tidal volume. So it helps us mathematically, right, if we know that they're 65 inches tall. And then we want to start them at somewhere around 6 mLs per kilo per the hospital protocol and or ARDS net protocol, then that's something that we can have a quick reference for and not have to worry about calculating immediately if we know that that person's 5'5". So you might see this out there. I just wanted to expose it to you.